Thank you so much. Uh, yeah, all right. So we will wait for 1 more minute and we will start how we get access to these. So, I personally am not sure, but in terms of the recording, probably the answer will be to fill out the feedback form at the very end, and then probably the you will get a link to the recording. Is that okay, Milo? But yeah, we will start in 1 minute because there is quite a lot of content to go through. And with such a lovely evening, you probably have much better things to be doing than listening to a talking head on the screen. Right, let's get going. So we will start with so today's presentation will be upper GI and hepatobiliary. Now, if you have any questions throughout, just let me know. Um, you can either shout out, you can raise your hand, you can try putting it into the chat. I will try to keep an eye on the chat, but no promises. In that, unless anybody has any questions, let's make a start. So, today we will talk about upper GI and about hepatobiliary systems, which are relatively large amount of content, but definitely can come up. Uh, but you've studied throughout the year, you've gone to your placements, you will be fine. Right. So today we will focus on the AKT slash OSCE, but mostly AKT. So the common important condition investigations management. Please review the LabMed lectures for the details on pathology. Are not going to do into eosin staining today. So we will focus on the presentations. We'll focus on dysphagia, so difficulty swallowing. We will focus on odynophagia, so pain while swallowing. And we will do some dyspepsia as well. Now, dyspepsia is essentially complex upper GI symptoms, essentially pain, discomfort, heartburn, acid reflux, nausea, and or vomiting, which is a quite a vague presentation if you ask me. So the patients may come in complaining, Doctor, I have indigestion. So that's usually pain in the abdomen after eating. And if you think about the differentials using your surgical sieve, there are a few which you have to consider. There is gastritis, inflammation of the stomach lining. There is ulcer, so we have a hole that started to form in the gastric lining. Always consider malignancies, especially in your slightly older population. There is functional dyspepsia, which we'll talk about, and sometimes gallstones. The pain doesn't always follow the rule of being on the right. Now, as we've mentioned, gastritis. It is inflammation of the stomach lining. It is extremely common, and the pains will involve things such as epigastric pain, especially after eating, nausea and vomiting, and in more severe cases, it may present with melena, the black tarry stools, or hematemesis, so vomiting blood. Now, before we start to think about individual conditions, we can focus a bit on what is actually going on. So we have our gastric mucosa in the stomach, we have the stomach contents, and we have our gastric defenses. So in the stomach, we have things which attack the mucosa and things which try to defend it. Primarily, we are worried about acid, which the stomach defends against with mucus and the immune cells. We have H. pylori, alcohol, smoking, caffeine, chili, fizzy drinks to some extent, and NSAIDs are the big bad of the gastric mucosa. So if you think about NSAIDs, they inhibit cyclooxygenase, the COX in the stomach, which inhibits production of the mucus, reduces the blood flow in the stomach, therefore there is red immune cells. Again, the prostaglandins inhibit the acid. Without prostaglandins, there is no brake on the acid. And steroids have this corticosteroids, like prednisolone, have similar function. Now, the role of stress is frankly not that big, but you could argue, if you wanted to, that there is some role of stress into that. So, in line with that, if we think about gastritis, it's all about things which can stress the mucosa out. So, if somebody is taking NSAIDs regularly, if somebody is using high dose corticosteroids, there is H. pylori infection, and stress maybe. And oftentimes there is a combination of things. Especially in gastritis, alcohol is quite a big factor. Smoking also contributes. And then we have everything else. And oftentimes there are multiple things which contribute to that. Now there are some other rare causes, more lab-med style, such as autoimmune gastritis. But vast majority of cases you will see can be attributed to alcohol, NSAIDs, H. pylori. So if you think about treatment of gastritis, inflamed stomach, we have too much gastric damage and too little gastric protection, in the most simple of terms. So we want to eliminate everything that is bad. So if you can, stop the NSAIDs, stop smoking, reduce alcohol, or ideally stop drinking. H. pylori, we will see, but if you have confirmed infection, ideally eradicate. So as we mentioned, the lifestyle factors are the first line, stop smoking, reduce alcohol, avoid irritants, stop NSAIDs, stop steroids if you can, and you can use over-the-counter antacids to neutralize the acid that again is the offending factor. Now, if that doesn't work, if you try all that and the patient still has symptoms, this is when you consider H. pylori, and if it is there, you treat. Now, in terms of the second line medications, you would use proton pump inhibitors, such as omeprazole or lansoprazole, to stop acid production. And similarly, you can use H2 blockers, such as famotidine, again to reduce production of acid. Now, thinking about H. pylori. It is a bacterium, infects the stomach, as you will know from the lab med, and triggers mucosal inflammation, decreases the production of protective mucus. Now, to test for H. pylori, you can do primarily two things. You can use stool PCR test, so get a stool sample and do PCR looking for H. pylori bacteria, or you can use the urea breath test. Now, for those tests to be accurate, you want a 2-week washout period, as if the patient takes PPI, the H. pylori can be suppressed, but it won't get eradicated with PPIs. You want the patient to stop taking omeprazole for 2 weeks, and they are not going to be happy about that. But this allows the H. pylori population to increase, and allows for accurate testing. Now, if you find positive evidence of H. pylori, this is where you want to treat. You don't want to use empiric treatment, you want to confirm their presence. Now, empiric treatment, you have the positive tests. Now, you don't have to memorize it, but currently in Oxford it's lansoprazole, so you want a PPI, you want amoxicillin, and you want clarithromycin, but again, it will differ based on resistances. But what you do want is triple therapy, which is a PPI, proton pump inhibitor, and two different antibiotics. Now, we are going back to our patient. It's not gastritis. There is still indigestion, but you're thinking about other differentials. What can it be? We have to consider peptic ulcer. Now, peptic ulcers. As we've discussed, it's the breakdown of epithelial lining. As you can see, we literally have a hole in the mucosa. Now, broadly, they are divided into the gastric and duodenal ulcers. Um, Textbooks or PASMED will say that allow you to differentiate them based on the reaction to eating. So in duodenal, the discomfort is better with eating. In peptic ulcers, it can be worse with eating. In the gastric ulcers, but there isn't actually good evidence for that being the case in clinical practice. But it can be a differentiator in MCQs, so that's potentially worth noting. Now, again, it presents as epigastric pain plus minus melena/hematemesis. And why are we worried about gastric ulcers? We've already alluded to melena and hematemesis bleeding. It can be chronic insidious bleeding from small blood vessels, which can present again with things like melena and iron deficiency anemia. However, if the ulcer erodes a larger artery, it can cause catastrophic hemorrhage, which could be life-threatening. Now, perforation is another big body. This is where the ulcer goes all the way through the gastric wall, and you have perforation. You have your air on abdominal XR or chest X-ray. And the problem with that is you have gastric contents leaking into the peritoneum. So obviously there is risk of things such as sepsis. And then we have the stricture formation, uh, which again is unfortunate, and if it close up, can cause dysphagia. Now, etiology of ulcers. You will recognize very quickly that this lecture has a recurrent theme. NSAIDs is big one. You don't want to if you hear that somebody is on naproxen, uh, you know, 2 times a day, every day for the past 6 months without any PPI cover, you are worried. Steroids, same story, with things such as prednisolone, dexamethasone. Not one-off, but prolonged use, definitely. H. pylori infection, classically with the famous experiment with drinking H. pylori and giving yourself a gastric ulcer. And smoking is a risk factor. And again, other things probably not helping, but less likely to cause ulcers on their own. So, I may or may not have copied the slide, but the treatment is very similar. But here with the ulcer, probably you will be moving into the second line relatively quickly with the PPIs. Now, if anybody wants to go interactive, I would be very happy to. So we will have one or two MCQs kind of sprung throughout this session. We have patient with 2-week wait referral for dysphagia. So what investigation will be performed? If anybody wants to unmute and tell us what investigation and why.
Would it be an OGD?
Yeah, and what are we looking for? Uh, why OGD? It's a simple answer.
Maybe for a peptic ulcer?
Hmm? That's one possibility. But in 2-week wait referrals, we are worried about cancers and malignant things. And the benefit of the OGD is that you get to just directly look, and also you can take biopsy at the same time. But no, that's up very, very good. Thank you so much. So, you may have noticed I haven't mentioned any investigations so far, but for a lot of these things, the definitive diagnosis, and indeed you can look for peptic ulcers that way, and definitely for emergency ulcers, you will be looking that way, is with endoscopy, the OGD. And you can see different things in here. On the left, we have gastritis, so the red, inflamed, angry mucosa. Here we have ulcer, in this case a duodenal ulcer, but the stomach ulcer will look very similar. And here we have something that looks not great. In this case, it's written it's a gastric adenoma, but I could easily imagine this being an adenocarcinoma as well. Now, the question below, do you scope everyone with indigestion? The answer is no. Now, again, we have another question. 59-year-old man, history of recurrent heartburn, presents to GP, reporting he has started to get a sensation of food getting stuck in his chest. Doesn't bother him much, just started to choose softer foods. What is the most appropriate management plan? Any takers?
Maybe a 2-week wait referral?
Absolutely. And what symptom made you choose that option?
Getting stuck in his chest?
Absolutely. So that is dysphagia. We are things getting stuck. He's moving solids to liquids. So that's definitely a red flag, and you definitely want to scope that person. So, in terms of the criteria for endoscopy, you want to look at their age. Now, 25-year-old is unlikely to have cancer, still could have, but you are looking at people 55 or above, and then do they have any alarm symptoms? So it's anemia, it's loss of weight, it's anorexia or early satiety. Uh, it has to be recent onset and progressive, melena and hematemesis. And I definitely would add to that, as we discussed, dysphagia, solids to liquids. Now, in terms of the questions, you definitely want to scope someone who is above 55 and with any of those symptoms. You would scope people who are not responding to standard treatment for uh, things such as heartburn or epigastric pain. However, if you are suspicious, you can scope somebody with an alarm symptom that is below 55. So let's look at the malignancies. Now, the gastric cancer. The risk factors is chronic gastritis or presence of ulcers, smoking, as with most things, obesity is a risk factor as well, and high salt diet. If you remember from LabMed about Japanese population having high risk of stomach cancer. Now the symptoms are the alarm symptoms. We have early satiety, we have epigastric pain, and there may be melena or hematemesis uh, or anemia from the chronic bleeding. Now the treatment is total or partial gastrectomy, cut it out if it's not spread yet, plus minus radio or chemotherapy. And here you can see Ru and Y total gastrectomy. Now, when we think about unexplained symptoms, there is functional dyspepsia as well, which is essentially dyspepsia. You scope them because nothing you've done so far has worked, and it's perfectly normal. It is very common, and if you go onto the gastro ward, you will see quite a few of those patients. There is epigastric pain symptom, postprandial distress, but it's primarily about the functional symptoms. It's the disconnect between the brain perception and what is actually happening. You want to reduce the risk factors, you want to optimize the lifestyle, and you want to assess for stress, anxiety, depression, and manage those accordingly. And however, with functional stuff, you want to consider other causes, gallstones, cardiac. It is a diagnosis of exclusion in the end, but yeah. Next question. 26-year-old woman presents to her GP with a 4-week history of mild epigastric discomfort following eating. She has not lost weight, denies melena. She smokes 20 a day. The most appropriate initial management plan.
Is it the top one?
Yes. Yes, it is. Now, this is a 26-year-old woman, so malignancy is going down just because of the age. There is mild epigastric discomfort, and it's following eating, so looks very much like that postprandial distress syndrome. She hasn't lost any weight, no melena, so there is no alarm symptoms really. Well, she's smoking 20 a day, we could work on that. And anyway, with somebody with dyspepsia and no alarm symptoms, that's how you would start. You would optimize the lifestyle, consider antacids, and see what happens. Now we are going a bit higher. Heartburn. It is burning pain in the chest, usually worse on lying down. Now, differentials you are considering are GERD, the gastroesophageal reflux disease, esophagitis. You think about malignancies, and for the love of everything that's holy, please do consider cardiac. Um, Now, not every heartburn actually comes from the heart, but there is a reason why it has a name. It's the same region of the chest as the heart. And literally yesterday, I was doing CPR on a lady that thought that she had heartburn for 3 days and arrested 5 minutes before we got to her in the ambulance. She didn't make it. So if that pain is sounding a bit more heart like crushing chest pain, or if it's going suspiciously long and not responding to half a bottle of Gaviscon? Think again, pretty please. So, back to the usual stuff. We have GERD. It is common. Indeed, a lot of population will have some degree of reflux, and it is a very common cause of primary GP appointments. Now, essentially, the lower esophageal sphincter, not stricture, sphincter, doesn't close properly slash fully. There are multiple risk factors. We have smoking, alcohol, caffeine, potentially stress. Obesity is definitely a risk factor. Position, so it's worse on lying down and better when you are upright. Some drugs can weaken the lower esophageal sphincter, as well as pregnancy is a big risk factor. Now, hiatus hernia is a classical anatomic variant that can trigger GERD, um, but actually it's quite rare. And this is essentially where the lower esophageal sphincter moves above the diaphragm, so it doesn't have the support from the diaphragm. Now, the typical symptoms of GERD is heartburn, so this stinging, a very sharp pain in the chest, acid brush, so the sensation of acid taste at the back of your throat, belching, and other symptoms may involve regurgitation, so the food coming back into the mouth, sore throat, odynophagia, so painful swallowing, nighttime cough. As you can imagine, nighttime is worse because they are lying down. And the key thing to ask the patient is, what do they mean by reflux? Elicit the specific symptoms. Ask them about the pain. Exclude crushing chest pain, pretty please. Now, complications of chronic GERD. Barrett's esophagus. I'm not going to go into too much detail as that's very much lab med, but it's metaplasia. The columnar cells replace the squamous cells that usually form part of the lower esophagus. Repeated irritation, so primarily GERD, and it is a big risk factor for esophageal adenocarcinoma, so you will want to prophylactically scope these patients regularly. Now, in terms of the third, upper two-thirds of the esophagus, that's usually esophageal squamous cell carcinoma, and here the risk factor is long history of smoking and alcohol misuse. So yeah, again, mechanism is the same. Sphincter not closing fully, irritation, chronic irritation of the lower third of the esophagus. Now, trying to manage GERD, you want the patient to stop smoking, reduce their alcohol intake, reduce caffeine intake, and if that's not working, you try to optimize the medical management, stop NSAIDs, stop corticosteroids, use over-the-counter antacids. If that doesn't work, you can prescribe PPIs such as omeprazole or lansoprazole, or H2 blockers such as famotidine to block production of acid. And as you can see, we are coming back to the same story. We will be going in circles. Now, in terms of GERD, one thing to say that H. pylori is not relevant as much in here. So maybe cross that line out. Now, the final line of management, if nothing is working, patient is very distressed, and you've exhausted your medical management, is the surgical management, such as Nissen fan application to strengthen the lower esophageal sphincter. Going on to esophagitis. It's inflammation of the esophagus. Reflux esophagitis, we've pretty much discussed. There is infective esophagitis, which is rare, but you can have candida, and then you are thinking about HIV, potentially transplant patients. I wouldn't worry too much about viral. I mean, eosinophilic would be an obscure AKT question, but this will be the patient with asthma that all of a sudden develops chest pains. Yeah, so we have heartburn, hematemesis melina if it's really bad, sore throat, sometimes dysphagia. And again, with management, we very much discussed. Wouldn't worry too much, especially at your stage, about managing infective or eosinophilic esophagitis. Did we say we will be coming back in circles? Yes, we are. Now the big body, esophageal cancer. We've already touched upon it. The symptoms are again similar, heartburn, but here regurgitation is more relevant. Belching as well, sore throat maybe, odynophagia, painful swallowing, acid brush. But now we are talking about the globus sensation as well, and the big bodies, which definitely make you think about esophageal cancer, like earlier in this presentation. Dysphagia, difficulty swallowing, having to go for the soft foods and then liquids. And melena and hematemesis definitely should prompt you to do a 2-week weight referral. And the general cancer symptoms, weight loss, anorexia, palpable lymph nodes, especially the Virchow node, the left supraclavicular lymph node. Now, dysphagia is a big red flag, so you want to scope them. Age above 55 and alarm symptom we have discussed before, want to scope them. Persistent heartburn that hasn't responded to anything else, you want to scope them. So again, a reminder, those are pretty much your typical cancer red flags, perhaps with the addition of melena and hematemesis, kind of localizing it a bit, as well as anorexia/early satiety. So we have another MCQ, 50-year-old man, grade 3 squamous cell carcinoma, midway down his esophagus, so in a place you would expect it. CT scan shows no evidence of spread or metastasis. Otherwise healthy, walks 2 miles a day. Obviously, the answer in your OSCE station will be refer to MDT. But what treatment do you think that he will receive? Anyone? Any guess? We are here to learn.
I'm not sure if the grade means that it's invaded the basement membrane, but if not, maybe you could do the first one and resect it.
Hmm? Yeah, as far as I remember, grade 3 is a bit too late for that, but that's definitely a good guess. So in this case, you want to remove the entire esophagus. But that's definitely a very good guess. Uh, so for esophageal cancer, you typically want to you usually will remove the entire esophagus and essentially reshape the stomach to form a new esophagus. This is in cases like the one we've just talked about, where the cancer hasn't spread yet. Uh, so you'll go with your surgical treatment, plus minus chemo, and yeah, radical chemoradiotherapy. Now, if the tumor has already metastasized, then that is off the table. Or if the patient has already very weak baseline and won't tolerate a major surgery like this, You can insert esophageal stent to essentially keep the lumen open and allow the patient to swallow liquids and maybe very soft, small solids. Now, interesting thing you will see in ED, the patient can get a bit over enthusiastic when you do that and try to eat, you know, a steak or something, and then come back in ED because the food is, that steak is now stuck. Fun thing, you can try to dislodge these with fizzy drinks, like essentially give them a can of Coke and see whether it helps it to pass. But if it doesn't work, you will need to go back with the OGD and fish it out. And yeah, palliative radio and chemotherapy is also an option. Right, dyspepsia. We've talked a lot about dyspepsia. And the key problem with dyspepsia is that there is multiple things which can cause dyspepsia. Some of them may coexist, maybe a bit of esophagitis in patient with GERD. They may have coexisting peptic ulcer. And as we've discussed, they are managed, investigated, primarily the same. So here is a nice summary from the Handbook of Clinical Medicine. So essentially you ask yourself, the first question is, any red flags? If yes, scope them. If not, start with the lifestyle changes. If that doesn't work, investigate for H. pylori. If it is positive, treat H. pylori. If not, do PPIs or H2 blockers. And then think later. If it doesn't improve, consider scoping. Right. Now, differentials for dysphagia, we've already discussed. It's something you have to investigate. And you have to exclude the malignant things. However, there are a few other things which are not malignant, but those are to consider when the OGD is clear or OGD shows nothing scary. You can have strictures in the esophagus, potentially due to ulcer. You can have pharyngeal pouch. You can have a foreign body. And there is a few different other things. Now, of the things to consider for you, the stricture, it's a benign narrowing of the esophagus, can be secondary to untreated GORD or esophagitis, may be developmental, somebody was born with it, and usually can be managed conservatively, but you can try to dilate it with the help of an OGD. So we have 76-year-old man at his GP, 2-month history or like food is getting stuck when he swallows. Now, sometimes he said that he can feel a lump in his throat when that happens, and it's accompanied by bad breath. So, what is the most likely diagnosis here?
Is it a pharyngeal pouch?
That's correct. So, pharyngeal pouch. You can see a cartoon representation here. It presents essentially you have the symptoms of difficulty swallowing, yes, but there is halitosis, which is bad smelling breath because you have a bunch of food sitting in there, and regurgitation. So it will then come back up into the mouth. There may be presence of a lump which appears after eating, but that's not always the case. And generally, it's your elderly patient. This patient was 76. We don't really know why they develop. You can treat them conservatively, uh, but if it's really interfering and the patient is in good enough health, you can consider surgical repair. Now, here the important question which may come up, It's pretty much the only presentation these days where you would consider doing a barium swallow, as you can miss pharyngeal pouch on an OGD, but it will show up nicely on a barium swallow. But with those symptoms, you would probably scope them anyway. Now we have 81-year-old female, 2-month history, feeling like food sometimes gets stuck when she swallows. She's been a slow eater. Now she has to spend even longer because she's waiting to it to go down. No weight loss. What investigation is going to give us the diagnosis?
Maybe a barium swallow because yeah, it could be an outpouching.
Definitely a good idea, but this one is slightly different. She's waiting for it to go down. There isn't any regurgitation. Now here the answer is esophageal manometry, and that's because we are thinking about achalasia. In this case, we have essentially motility of the esophagus is out of whack, so there is less peristalsis. The lower esophageal sphincter stays contracted when swallowing, so she have to wait for the food to go down. Now, typically, it's lifelong, can be slowly progressive. The patients are eating slow, food is getting stuck, and esophageal manometry is the investigation of choice. Now, management, depending on the patient, it's the classical triad of conservative, medical, surgical. Now, surgical would be your laparoscopic cardiomyotomy. So essentially, we are cutting the lower esophageal sphincter so it relaxes more easily. Now, hematemesis melena, the big bodies, there are multiple differentials. You have to consider the malignant ones, but it may be swallowed blood from epistaxis or post-tonsillectomy bleed, especially in kids. In esophagus, there are multiple causes, some of which we'll discuss, but you need to investigate those as malignancy is definitely on the cards. Now we are going to speed up in a second, but we have 34-year-old man in the emergency department vomiting red blood, smoking history 10 cigarettes for 15 years, vomited 4 times this afternoon, and the most recent time showed bright red blood. What is the most likely diagnosis? Okay, so for the sake of time, this is a classical presentation of Mallory-Weiss tear. And why is that? Now, Mallory-Weiss tear is tear in the esophageal mucosa. It is a superficial tear. It doesn't go all the way down. And it's usually pretty much always due to repeated retching. So patient who has been vomiting multiple times for whatever cause, they may develop a small tear like that, and they will start vomiting bright red blood, get scared and present to A&E. Now, luckily, the treatment for those is reassure and discharge, as it will just heal on its own. Now, the scary things are esophageal varices. The patient will have background of liver disease, chronic alcohol use typically, and there is high risk of death if they rupture, as it will be a catastrophic bleed. So you want urgent endoscopy to try to treat those before they burst. And yeah, upper GI bleeds, these are scary. I wouldn't want to be managing one, but you will resuscitate the patient. You will cover how to in year 5 and do an urgent scope to identify the cause and treat with things such as biodigation, gluing, cauterization. There are a few other options as well. Now, there is feedback link, but you can do that in a minute because we will go to the HPB surgery. Any questions so far? Probably many, so do not be afraid of stopping me and asking questions as we go along. But let's whiz through hepatobiliary. Many different things, but we'll try to work through them and make them a bit easier. So we are F1 on SEU. We will be working on AKTs, common important investigations management, surgical presentations, review the lab med stuff for pathology, hepatitis, chronic liver disease, PSC, PPC, the weird and wonderful things, and liver and bile duct malignancies. We will cover one or two important malignancies, but not the rare stuff. So, a quick intro question. 45-year-old woman presents to surgical emergency unit, 12-hour history of right upper quadrant pain and fever. Reports experiencing similar bouts of pain on and off for the last 6 months, but she says the pain usually disappears after a few hours. How are you going to investigate her? Any takers?
Would you start with an ultrasound?
Very much so. Now, the right upper quadrant pain and fever make you think, and that colicky nature makes you think something is wrong with the bile system. Now, these patients will have background of cholelithiasis, so presence of gallstones. These are usually asymptomatic, and plenty of people will have gallstones throughout their life, and usually they don't cause problems. Unless they decide to go on a walk. Now, biliary colic is also common. These are small stones. They cause pain as they travel through the biliary tree and eventually get past. Now, that will cause severe right upper quadrant pain, potentially with some nausea and vomiting, but there will be no fever and no much of other symptoms. As they say, it can last for 3 to 6 hours, usually brought on or made worse by eating as the gallbladder contracts. And you do an ultrasound to try to, you can do an ultrasound to try to identify them, but the treatment is reassure and discharge, at least acutely. Now, in terms of the investigations, the blood tests will be normal. They will not have a fever. You will want to do abdo ultrasound, and you may see the stones in the gallbladder. Now, as we've mentioned, acutely they are not admitted. You give them pain relief for the acute flare. Recommend a low-fat diet to try to trigger the colic less. But if it's happening repeatedly, you would arrange a follow-up and consider routine cholecystectomy. Now, things can bad when things get inflamed. Acute cholecystitis, we have inflammation of the gallbladder. Usually, it's secondary to stones. Now, the history, the patient again will have right upper quadrant pain, but then now they will have fever, their inflammatory markers will be raised. Again, there may be some nausea and vomiting. As a side note, there is acalculous cholecystitis when there is no stone, but it's very minor and this or your critically ill patient in ICU. If you have limited capacity, I wouldn't worry too much about acalculous cholecystitis. Now, acute cholecystitis due to gallstone is quite common. You will probably see it at some point. And it's, as we've mentioned, right upper quadrant pain. They are febrile. The Murphy sign is positive. So the Murphy sign is you press in the right upper quadrant and you ask the patient to take a deep breath in, and they will have sudden catch of pain. And this indicates that the gallbladder is inflamed. Now, the blood tests classically will be normal or maybe normal-ish in real life, but very minor elevation, most likely normal. The white blood count and CRP will be raised as there is inflammation. You again do abdo ultrasound, and you will see a thickened wall, which is inflamed gallbladder. Now, how to manage acute cholecystitis? You want to give them IV antibiotics as there is infection happening. Keep them nil by mouth because you are considering doing lap chole. Or potentially cholecystostomy if they aren't fit for removal of the gallbladder. But that pretty much is symptom control without solving the cause. Cholecystectomy, very common procedure. Wouldn't be too unreasonable, definitely in year 6. Potentially now to think about what can happen when you do it. Infection is a risk. Bleeding can happen as with any surgery. There are local structures. You have to consider the bile ducts, common hepatic ducts. Damage is rare, but essentially if you block the common hepatic duct, the liver will go into failure. So if this occurs, you will need to repair it. Common bile duct, same story. Bowel perf, if you cut into the bowel, and the liver can also get lacerated. Now the big one, which is the common, is the post-cholecystectomy syndrome. So again, it's very common, 1 in 10 patients post-lap chole, and they will have ongoing diarrhea and GI upset. And you treat that with bile salt sequestrants and other general complications with any surgery. And yeah, as with any surgery, patients can die. Now we have 45-year-old female, right upper quadrant pain, scleral icterus. Recent abdo ultrasound showed stones in her gallbladder. How are we going to investigate her?
MRCP.
MRCP, amazing. Yes, so just to double check for everyone, scleral icterus means jaundice, which is visible in the whites of the eyes, and this is usually where it first is visible. We have history of gallstones. We are doing MRCP as we are worried about the common bile duct. Now, biliary obstruction, we have larger stone. It can be choledolithiasis if we have stone in the biliary tree. Typically, the history with the right upper quadrant pain, typically with jaundice, as now we are blocking the bile outflow from the liver. Dark urine, pale stools. Same story, we have conjugated bilirubin. And it can present like an episode of biliary colic first. So again, with biliary obstruction, with choledolithiasis, we have right upper quadrant tenderness, plus minus jaundice. They are not infected yet, so they will be afebrile. Now ALK-Phos and GGT will be raised as the liver outflow is blocked. ALT and AST will be normal. Now in real life, it can be slightly raised. And in questions, indeed, it may be slightly raised as well. What you are looking for is the discrepancy. The ALP will be sky high, ALT and AST will be slightly raised. It's the question of which one is raised more relative to the upper limit of normal. And conjugated bilirubin is raised. And yeah, the key investigation here is MRCP. But you will also do an abdo ultrasound to try to look for the gallstones. Now, the biliary obstruction. You will keep them nil by mouth as you are thinking about managing that in a more surgical manner. You will give them analgesia and antiemetics, don't torture your patients. And ERCP for extraction of the stone. And typically, if they are developing this type of complication, they will need lab chole as well. The big body is ERCP complication, perforation of the gut, can happen. That's why we don't scope everyone. Every time you put a scope somewhere, there is a risk it will go into a place you don't want it to go. And ERCP is also not free of that. I've seen perforations of things before, not fun. But pancreatitis is the one you fear. Now, in terms of the gallstone in the common biliary tree, common hepatic duct or common biliary duct, it can become infected. And this is your Charcot triad, your right upper quadrant pain, fever, and jaundice. In elderly, they can also get confusion and shock, and this is Reynolds pentat, and it is a bad prognostic factor. So again, we've talked about it when I was doing the lab med revision of GI, and it still applies. Biliary colic. It's just right upper quadrant pain. They will get discharged home. Cholecystitis. Now there is fever and inflammation involved. They will probably come in for club coli. Now ascending cholangitis, the big body, right upper quadrant pain, fever, jaundice as the liver outflow is blocked. So here your alk-phos and GGT will be very raised out of proportion. Your ALT and AST will be probably raised, but not as much. Bilirubin will be very high, conjugated bilirubin. If you do specifics, there will be inflammation, and MRCP is your investigation of choice. Now, ascending cholangitis can easily turn into sepsis, so most likely you will start with stabilizing the patient and doing sepsis 6 anyway. And to manage ascending cholangitis, you want to do source control, and that is ERCP to fish out that offending stone. Potentially, if it's really mild ascending cholangitis, you could try antibiotics first. Okay, we have another patient. F1 life never stops giving. 36-year-old woman, surgical ward, abdo pain and vomiting. She had a procedure to remove a gallstone earlier that day. What could it be? Her heart rate is 109, BP relatively okay, temperature 38.6, saturating okay, respirate 20. What are we thinking of?
Pancreatitis?
Yes. So that procedure was most likely ERCP, and the big complication that is the most common of the bad complications of ERCP is pancreatitis. Another question. 62-year-old man, severe epigastric pain, radiates around to the left, amylase level comes back at 1050 with the normal range between 70 to 300. What further investigation do we need to make the diagnosis of pancreatitis?
Is it no further test required?
Yes, it is. So with the history, the elevated amylase, which is at least three times the upper limit of normal, so in this case above 900. This patient is at 1050, so this confirms the diagnosis of pancreatitis. Now we have inflammation and autodigestion of the pancreas. Never ever fuck with the pancreas, and that is true. It starts to digest itself. It's not pretty, it's not nice. Patient is unwell very quickly. Now, the causes of pancreatitis. Any takers for the three most common? Don't worry. Now, the mnemonic, I get smashed. Now, the most commons in the UK are actually gallstones. Not surprising, gallstones are common. Ethanol, alcohol misuse is very common. ERCP is actually quite a common cause. You also have to consider things like idiopathic. Now, if anybody gets that specific scorpion sting on the ward, please call me. I would love to see it, but this is the UK. You can always try to make your consultant angry by starting with the scorpion sting and smiling very cheekily. I leave that up to you whether you want to try that. Now, patient with acute pancreatitis will be scary. The observations will be unwell. They will be all over the place. You have epigastric central abdominal pain. And because they are so unwell, you are considering sepsis, ruptured AAA, bowel perf, intra-abdominal hemorrhage. This is the big sick patient. Now, here you can see the characteristic signs of pancreatitis. On the left, we have the Cullen sign, which is the bruising around the umbilicus, and the Gray-Turner sign, which is bruising on the flanks. However, don't rely on those for the diagnosis. These are late signs, so if the patient already has those, they are really unwell. So, for proper diagnosis of pancreatitis, you need 2 out of 3. So you need consistent history and exam. You will do amylase or lipase, depending on the trust you are in, one of the two. And consistent radiology, such as CT. Now, this rarely gets fulfilled because it's rarely done, but potentially you could see pancreatitis on CT. You would usually also do abdo ultrasound to try to find a cause such as gallstones. Now, you don't have to learn all of this, definitely not yet. PassMed loves questions of things such as calcium, so we will cover calcium. But the three key messages of how to decide whether it will be a bad pancreatitis or just a moderately bad pancreatitis. Now, in terms of calcium, if you remember from I Get Smashed, high calcium is a potential cause, but the low calcium is a consequence, so the calcium levels may drop. And if the calcium levels are low, this is your indicator that this is going to be the big bad pancreatitis. Another important thing, which is actually relevant, is that amylase level is not prognostic. It doesn't matter whether that patient we've discussed earlier had amylase of 1000 or 5000. It doesn't tell you anything about how bad his pancreatitis will be, just that he has pancreatitis. Now, question to the floor. Most important feature of management of acute pancreatitis. I'm not going to wait too much as you guys don't have to learn management just yet for most of things. but you want to be monitoring fluids and urine output. In terms of the important stuff, fluids, urine output, don't want them to go into AKI, analgesia and antiemetics, and supportive management. You would do ERCP if there is a confirmed gallstone, and stop them drinking alcohol. You don't want to give them steroids if you think about steroid use actually can cause pancreatitis and make it unhappy. Now, complications, they can get collections. The pancreas may necrose and just liquefy into a nasty mess. Or they can get chronic pancreatitis, especially if they have repeated bouts of acute pancreatitis. But you don't need to know much about those apart from the fact that they exist. If the pancreatitis is still there, you want to do a CT scan. They may have a nasty collection which may require drainage. But you can, if it's relatively small, you can just wait to resolve. In terms of chronic pancreatitis, their function will be bad. They may need creon, so the enzyme replacement, to absorb nutrients. They may need insulin because their beta cells have also been destroyed. And they develop something called type 3C diabetes. Another question. 60-year-old female, alcohol abuse, GP, 2-month history of pale foul-smelling stools, difficult to flush, lost a lot of weight in the last year. What test most appropriate in this context?
Would it be fecal elastase?
Yes. So we are worried that she has things such as chronic pancreatitis. Her pancreas is not functioning well. She's not absorbing nutrients, so she's losing weight. Fecal elastase allows us to evaluate the function of her pancreas. So the pale, foul-smelling stools, which are difficult to flush, is classical sign of exocrine insufficiency. So you want to treat that with creon, vitamins, and endocrine insufficiency. Diabetes may need insulin treatment. Yep, so chronic pancreatitis. If she had really bad bout of acute pancreatitis, it may have destroyed her pancreas. And cystic fibrosis usually presents in young kids, can be picked up in newborn screening. Now, 70-year-old male, skin becomes yellow over the past few days, no pain, a bit tired. What investigation do you want to request?
A CT scan, maybe?
Yeah, what are you worried about?
A stone in the common bile duct.
A good call, but it's painless, and the fact that it's painless is what makes us very, very worried. Painless jaundice. If you have patient who is turning yellow, you hope that they have been to some foreign country and picked up hepatitis, but if not, it's it's pancreatic cancer until proven otherwise. Can later on develop central abdominal pain, but that is very late. And indeed, most patients present late and typically have metastasis everywhere. If you manage to catch one before it turns metastatic, you can do Whipple procedure. Complicated one, but essentially resect head of pancreas, duodenum, uh, gallbladder with a bit of bile duct, and reconstruct what's left into a functioning GI system. Now, as we've discussed, this patient has been to South Africa and now she has fever and malaise and a bit of right upper quadrant pain, so we are less worried. And given that the question gives us travel history, this is a patient with hepatitis A. Hepatitis C you would consider in your IV drug users, uh, or people who have lots of sexual activity. Now, as we discussed, hepatitis A can mimic things, ascending cholangitis is on the differential, but these are all the weird and wonderful things. With history, typically will give you clear pointers. Okay, that's everything for today. We are finishing right on time. If you guys could scan the QR code, give me some feedback, tell me whether I've done well, whether I've done less well, which is probably the case. And this is a requirement to get the slides. So you probably want to do that. Any questions that you have thought of, wanted to ask? Um, I don't see anything in the chat.
Thank you very much, Casper.
No worries. And yeah, if you have any questions, um, feel free to ask me now, email the organizers. But I assume that you've managed to get through the feedback form. So thank you so much for joining today. I hope that you'll have lovely rest of the day and survive the heat wave.
You
See
too.
you.
Thank
Bye.
you. Thank you.